So I'm going to share my screen. Okay. So I'm going to start off with the process pointers so that you can make sure that you've got your mics muted. It really helps stop with the feedback so everyone can hear. We are recording this session, so the good news is if you have any friends or colleagues who can't make it this evening, who may be watching the football, then they can watch it on YouTube from tomorrow. Do use the chat window, so open up the chat window and pop in any questions or thoughts, anything you want to share as we go along. Do let us know if you've got any feedback, any ideas for future webinars. We've got a Facebook page called Bridges Self-Management Community. That's a really good place to carry on any discussion. If we get into it in the second half and we have to cut you off, then that's a good place to go to continue those discussions and to network. We've got about half an hour presentation and about half an hour discussion, so we will be done by 8:30. This webinar is on quality improvement, and we decided to call it Making Friends with Quality Improvement and making the case to hold on to the good, because speaking to some of you, it seems that as we move out of this command and control phase, then the kind of red tape and the slowness is kind of creeping back in. And in those early stages, people seem to have the sense of mucking in, making do, being quite inventive. Many of you told us some really cool innovations, things that you were just being able to put into place in a way that you wouldn't have been able to do before. And now a number of people that we've been speaking to over the last couple of weeks have felt quite frustrated. Some are feeling a bit angry. There's a lot of fatigue because whilst you might be quite happy to make do for a short period of time, as time goes on, that can be quite wearing. And many people feeling quite powerless. And quite a few clinicians can sometimes see quality improvement as being something that's external to their team, that's something that's kind of over there. There's a quality improvement team that maybe come in and get you to do patient surveys or things like that. Bridges, we know that QI tools are really, really important for teams that go through training, for them then to implement changes that they want to make within their team. It gives them that structure. And many people have been talking about how we have a once-in-a-generation chance to really rethink and redesign services around what matters most to people. So we thought it would be a really good time to look at quality improvement. But before we go any further, what's one word for how you're feeling or for what's going on for you right now? And I'll get Fiona to read out some of the things that you're saying. The one on the right, by the way, is my son after he got given his first milkshake, but then it actually wasn't his milkshake, so he had to give it back again.
Yeah, I've felt a bit like him at times.
Yeah, I know.
Lots of people tired, swept along, waiting, weary, grateful, a little bit powerless, excited, uncertain. Thank you. Any more? Yeah.
Okay.
Really get that people are tired. And
yeah. Okay. We will crack on then. So you've got three of us this evening, plus Fiona, who's managing the chat window and all of your questions and queries. We're really lucky to have Annette with us today. She is a professor of healthcare research at St. George's, and she'll be talking about the magic of QI in the second half. And first of all, you've got me, Katie Campion, the co-production and innovation lead at Bridges, and I'll be talking in the first half to Jenny, who is one of our fantastic Bridges associate trainers. So she helps us out when we do some of our workshops, and she's also a physiotherapist over in Wales. And she got in touch a few weeks ago to talk through a few things, and we managed to rope her into a webinar. So to kick us off, let me stop sharing my screen. Jenny, how are things at the moment where you are? How does it feel?
Well, it's been a challenging time, hasn't it? So I'm based in physiotherapy and neurology outpatients. I'm a Band 6 physiotherapist. And basically, we've gone from our normal face-to-face clinics to working remotely, so doing telephone and video consultation. I've been sort of trying to work out what my role is, because initially, as sort of the pandemic hit, I stopped working in outpatients and went to work up on the wards. Yeah, and it's just been a sort of a case of us finding our feet with new ways of working. We've got some members of staff who've had to shield at home, and so trying to work out how we can sort of keep them included in our team and still use them, or for them to continue to work, and how that's.
And does the pace of change still feel as it did a few months ago?
I would say things are different. So initially it was very much sort of crisis management. It's all hands on deck. It's where do we need to go, what do we need to do now to manage this, with the expectation, I think naively, that it would all be over and we'd go back to some level of normality, you know, sometime soon. I think the reality is that normality as it was is not going to be the same for a long time. So we're now kind of looking at the sort of medium to longer term to work out if the changes that we've made up to this point are good, and if we want to keep them, and how we want to try and move forward, and how we're going to move forward. And equally kind of then looking as kind of we've all been working, so our neuro outpatient team has sort of been working, doing the changes that we can to manage our patients, but kind of recognising now that, so the musculoskeletal physios have kind of been working together, the women's health physios have been working together, the community teams have been working together. So just trying to work out all the ideas and all the changes that we've all made, what kind of how we can collaborate and sort of bring things together.
So they've all been working quite separately in the kind of so far.
Yeah. But it does mean as soon as you try to draw more people into making decisions or trying to evolve something, everything gets a whole lot slower. And so there's a bit of sort of frustration with that, sort of feeling like we were making so much progress before, and now it's not quite as rapid. But equally, if you want something to really reflect the needs of patients and to sort of have a little bit more rigor to it, it takes time to produce something, and you want it to have longevity as well. So I sort of see the two sides of the coin.
And when we spoke I don't know, a few days ago, you used the phrase a series of fortunate events. Can you tell me a bit more about that?
Yeah, so as lockdown started here in Wales, both my team lead in neuro outpatients and our clinical lead with our community neuro rehab service both had to self-isolate due to family members having possible COVID symptoms. And it was before we had the testing, like the rapid testing that was sort of put in place a few weeks later. So it meant that instead of being redeployed into the acute setting as anyone in work was really, they sort of had a little bit of time away from work, or away from the acute setting, I suppose, to really look at the service, I suppose. They produced some really lovely like video resources. So again, in our neuro outpatient and our community neuro rehab service, kind of looking at producing some videos that we thought our patients might be able to look at, and you know, the familiar faces that they knew, and they might feel like they could perhaps participate in those. But it also meant that they could look at kind of the reorganisation of our service, which perhaps wouldn't have had that attention and that focus had all of our attentions been in the acute side. So it sort of meant that it felt like we had a little bit of a head start, pooling resources, yeah, and it just meant that things could get organised, I suppose.
So they kind of inadvertently had time to kind of take a step back and think more strategically about things.
Yeah.
And when you first got in touch with us, it's because your trust was putting together some COVID resources, a website. I know lots of trusts are doing something similar, so they want to produce something that's going to support people with COVID at home. Tell me a bit more about that, because you were quite keen that it wasn't just another kind of tick box exercise or a list of links, whatever.
Sorry, I'm talking over you. So this is just one of the many things, one of the many sort of projects that seems to be going on in parallel at the moment. Because of some of the online resources that our team produced, we sort of became involved in supporting the website being produced. And the idea is, in the longer term, this website will be a sort of self-management support tool for lots of patients accessing therapy. But in the shorter term, it's a starting point is with COVID-19 patients. And the reason I got in touch was because I just, in our role in neuro outpatients, one of the things I looked at was kind of all the resources that are out there. We tried to make a bit of a crib sheet so that we had sort of easy access to links and sort of descriptions of what were in those links, so that when we were doing our consultations, we could refer to things that we kind of knew the content of things. And so with this website, I was just keen that it isn't just another website that sort of is appropriate for patients with really high health literacy that are kind of maybe competent and confident to go out there and find the resources that are already there, that perhaps this resource is more accessible to patients who aren't sure about giving something a go. And just that idea that patient stories and the patient voice might just encourage somebody to try something that could be good for them to try, rather than it just being kind of another source of I suppose sort of patient information. I mean, this is a work in progress, and I think there's definitely an emphasis on getting something produced. Then the idea will be that this is kind of reviewed and added to. So I'm not quite sure. I feel like I'm on the very edge of it, just sort of trying to wave my self-management flag and sort of influence it as much as I can from the sideline.
Yeah. And have there been any QI tools that you guys have used in your team that you found useful?
So, yeah, so back in kind of coming back to neuro outpatients and our sort of service there, we're trying to evaluate what we've done up to this point, and we're using the Plan, Do, Study, Act cycle just to help us structure a bit of evaluation. And the main thing that we're doing at the moment is talking to our patients. So we've got a few questions that we're asking people about their experiences with the remote consultations, and we're kind of at the stage where we're still discussing the questions with the patients, to be honest, to see what their idea, whether they think they can get their experience across to us with these questions before we start asking them more routinely. But actually our whole physiotherapy service is being reorganised. Our physiotherapy department in our acute hospital, in the Heath Hospital, has been changed into it's currently a dormant ward. So all of those physios are no longer, so our clinical space is no longer available to us. So everyone's having to work differently. We do obviously have other sites within Cardiff where people are based, but it meant that it sort of pushed us all into this pretty significant reorganisation process. And we're just really keen with our patient group to try and get some feedback from our patients, so that as we go into this development process with our other physio colleagues, that we've got an idea of what's important to our patients. As part of this reorganisation process, we're looking at engaging with patients along the way, but it just feels like even at that first phase, trying to make sure that we've got some idea of what
you're not going off in the wrong direction, spending loads of time doing something that actually is not necessarily going to be that useful. Okay, so I think that's probably a good point to hand over to you, Annette. So I'm going to share my screen again, and hopefully, there we go. Let's go next slide.
Right, let's see if this works.
Okay.
Okay. Can everyone see that? Can you see a bit of nodding? Can I see some nodding? Yes, great. Okay. Thanks very much. So I said I would do a bit of a sales pitch for quality improvement and also talk through some of the components of it that I think are particularly useful, but then say a little bit about what I think some of the challenges that come with taking a quality improvement approach mean for the work that we do. My background as a social scientist, I have no clinical experience at all. So what I find most useful about these kind of webinars is an opportunity to hear from you about how this sort of stuff lands with your practice. And so I'm really looking forward to the discussion. So essentially, as we were just discussing, Jen mentioned the Plan, Do, Study, Act model that I've put up here. But one of the things that I would say in terms of selling quality improvement is it does give us an awful lot of models, frameworks and tools that help us as individuals and also as teams to think through some of the things we want to change and how we want to change them. So just give us a bit of structure to that kind of work, and that structure is so important for our thinking. I remember once teaching quality improvement to a group of health professionals, and in the end somebody said, I can't quite see yet how I'm going to use this on my work, but I'm definitely going to use it on my husband to get the garage sorted out. And I think that idea that these are skills and ways of thinking and little bits and pieces of helpful tools that we can use to help us with some of those tricky problems we encounter at work, but also in other areas of our lives. A lot of the time we spend ourselves thinking at the top of this iceberg about what on earth has just happened and reacting to that. So what has happened and what on earth are we going to do to fix it? And not thinking any kind of more deeply, not often having the time, in fact, to think more deeply about what's going on, what's been happening. You know, have we been here before? Are these kind of patterns and trends that we've kind of encountered in the workplace? So I always find this particular model useful for thinking through not only that reminder to reflect on whether we've been somewhere before, but also to recognise that quite a lot of what holds us back and enables us is wider than our own roles as individuals and teams, and actually lies within our organisations and their systems, and also wider forces. I mean, I think we've all been exposed to a lot of that in the last few months, of seeing how much is influenced by the wider context and also by how the organisations we work in function within that landscape. And so those systemic factors are important for understanding, and I think particularly we can often feel as individuals really frustrated by our inability to change things, particularly things that, you know, everyone has their hobby horse of something they'd like to fix at work. I think sometimes it can just be quite a useful starting point to recognise why those things haven't changed, that actually your role is important, but there are also a lot of other factors that lie around what you're doing that are often kind of sometimes enabling and just as often getting in the way. And then the bit I want to talk a bit more to today is this bottom element about kind of how we think and the kind of our mental models and how important that is to processes of change. And one of the things that quality improvement has addressed in recent years by some of its techniques, so things like experience-based co-design and the approach I'm going to talk about, which is patient and family-centered care, is to recognise that some of the magic of quality improvement lies in tackling head-on the ways that people are thinking about the service, so the ways that they're thinking about their work, the way they value what they do. And we know that most people have gone into kind of clinical practice because they want to make a difference to their patients, but they spend an awful lot of time filling out audit tools and doing checklists and doing things that maybe don't help them connect really tightly with why they do the work that they do. So I'm going to just talk very briefly about a study we did in some intensive care units in the UK that was using this US approach called patient and family-centered care. And what this approach does is it takes teams of health professionals, gives them some training so that they can go and sit alongside their patients and look out at their service and see it afresh for the first time. So the idea with this, particularly with patients who are receiving end-of-life care, was that they didn't involve a lot of kind of interviewing the patients or involving them in the work. And I think you're going to talk about co-production at a later webinar. So it wasn't really getting people in, these are very sick patients, but the idea was that you would have a kind of proxy for that by sitting by the patient and looking out at the service and seeing what the patient might be seeing in their environment. And I've just pulled up a couple of quotes from the study, which illustrate what it was like for the members of staff to look at the service. So they're sitting beside this patient, this practice development nurse observed that on one side there's a staff toilet, and on the other side there's a patient toilet. The patient who is very unwell like that, very poorly, we would leave the door open. But it meant it was very noisy, and the supper trolley came. Someone brought a hot meal which was inappropriate, and I looked around the room when the nurse left, and the last IV bag was still there, and it should have been taken out. And so this opportunity to just sit and reflect and look at the service gave people an opportunity to think about things that were actually quite small that they could fix. So, for example, propping the door open, that was something that they could fix, and they could think about which rooms they used for these patients on the ward. The second one is from a training lead, and who this is her experience. So she thought, I thought, oh gosh, it's such a stripped back experience. This poor man in his gown and his incontinence pad, and I felt it was very impersonal. The table was there, and there was his watch, and he did have a mobile phone, and his watch and his mobile phone were on the table, and you think he's not able to use those anymore, and those are bits of him as a person. So both these cases, the health professionals were looking at the service and seeing things that they hadn't seen for a while, and most importantly, it was reminding them that they were human beings, people who had histories and lives that they didn't necessarily often have time to sit back and reflect on. And that is often described when people talk about this particular patient and family-centered care initiative as where the kind of magic lies in the intervention, and that it makes people think, I want to go and fix this, and I want to go and fix it now, and I want to get other people to help me sort these things out. And often the things that are identified through these type of quality improvement programs are actually quite small things to fix. They're not expensive, and they're not transformational in the kind of wider systems way, but they accumulate. So they build a culture where people are listening and understanding what needs to change, and that accumulation of these little changes can often lead to bigger change within the organization, where people feel this is an organization that listens and tries to fix things. So I just wanted to talk about another study very briefly, and then I'll be done. So we currently have a study going on in the ICU unit at St George's, where we're looking at how innovations are being rolled out in practice. We started doing this during the kind of lockdown period, and we're carrying on over the next year. And partly this came from my colleagues who work on the ICU, who felt that so much fantastic transformational change had happened at the start of the process, really energizing change. And they were concerned that some of those changes might be lost. Things that were really good before might be forgotten and not come back. And as one of my colleagues described, he said, there's an ebb and flow of energy to drive change at the moment. And I think a number of you commented on that. At the moment, we're often feeling quite tired, and we've been putting an awful lot of time and energy and of ourselves into these change processes, but actually they are going on and continuing all the time, and so that has real implications for how you support the workforce. Just to talk through a couple of the changes we've seen in the ICU at St George's, this is the Royal Society of Arts framework for thinking about the crisis response measures that we've seen, and I find it really helpful to think about some of these different ways we respond to innovations, and to help us in a way. It's another framework that you can use to help think about change processes. I mean, what they argue when we're thinking about recovery here is that there are quite a few things that we've been doing just because we're in a crisis period. And I would put command and control models in there. So we've been living under quite an instructional regime, and that isn't so necessary anymore, and that can come to an end. So to recognize the things that we did that were really important and were part of a process, but that we can now finish. I think the positive thing that we spend a lot of time thinking about is the amplifying. So these are the things that we've started to do differently, and that actually are really critical, and that we want to carry on. We want to find a way of resourcing. We want to get colleagues to support so that we can carry them on. One example from the ICU was that they'd set up a WhatsApp group between the team so that they could communicate very rapid bits of information, and also work very, very fast. So when they brought the new ventilators into the ICU, they had 6 different ventilators, but they could message each other and find out how to use the different, apparently you only need a couple of settings like you do on a washing machine. So it's just finding out what those were so they could get going very, very quickly. So the restart element is about those things that we really don't want to get lost from the services when we've been doing, as Jen was mentioning, some more pared down elements of our service, and there are things we know we really want to get back. And so what do we need to restart? And I think there are a number of those things that I'm sure all of you can kind of identify in your setting. And then this interesting group, which I think has a more of an emotional connection, and that's the letting go. So things we've been doing for a really long time and we've now recognized are maybe not so necessary, and how do we let go of those? And they may be things we've wanted to have let go of for a while and that we can see this opportunity, but how do we persuade our colleagues to let go of things that they're very attached to? And I think that might be something that we could discuss. I think across all of this, there's an important dimension that's got a little bit lost from the quality improvement discussion over the last few months, and that is where the patient voice can come into this process. Because I think we've been so busy doing, and we tend to be very good in quality improvement at listening to patients. It's a big part of the process is hearing what patients and their families want. But we've been doing so much and we've been doing it so fast. I think there's a little bit of a danger that a lot of these decisions will be made without the patients alongside us. And particularly when we think about things like bringing in new technology, we know it works for some people, but we know it doesn't work for all. And so thinking about how we give the kind of differentiated service that really meets people's needs, I would say that we're at a point now where we need to think about how we bring the patient voice back into the quality improvement process to make sure that the changes we make going forward are the changes that work for everybody. And I've just picked some resources on the end that I think Kelly was going to share through the chat as well. That's okay.
Yeah, we'll make sure those go up. And so that kind of leads me on quite nicely to the fact that our next webinar, which will be in 3 weeks' time, we'll be looking at co-production. So how you bring that patient voice back in. Just before we've got a couple of minutes before we go into the Q&A part, and I just wanted to share one more thing with you guys. So this is the grid that Annette just showed, and we are in the process of developing Bridges online training. We've been playing around with some different online tools and whiteboards, and some of you very kindly took part in a bit of an experiment, and I asked you to all put post-it notes on a big collaborative mural board which had this on it. And I just wanted to share with you a couple of things that people had said, because actually there were some really, really lovely improvements and changes that we'd seen. So some of the things that people wanted to let go of, all the meetings, the default of having face-to-face appointments, weekly triage meetings to assess referrals and assign them to a waiting list, initial assessment forms were changing, and then the things that people really wanted to amplify, so things that people had started doing during the current crisis and wanted to continue afterwards: more meaningful interactions, less restricted by professional boundaries, skill sharing, family directed inpatient discharge, which I thought was a pretty interesting one, further triage by phone, avoiding unnecessary home visits, streamlining, swift response and initial management of referrals rather than waiting for a weekly meeting and then placing someone on a waiting list, and increased use and acceptance of technology both within the service and within service users, because of course we just had to crack on and use these things. And as I said, the next webinar will be on co-production, but now we would like to start our Q&A. So Fiona, I will hand over to you.
Thank you. Thanks, Katie. Just hot off the press, I think we've got Glenn Roberts nailed for the session on co-production in the middle of July. So some of you may be familiar with him already, but so that'll be really good. And I think some of the things that have been picked up today would really lend itself to that session as well. So I had a little look at some of the questions that people posted before they came, and it's really helpful when we get even just a few of you just posting questions. And often with the webinars, particularly when it's Evie and I, we overrun and there isn't time for many questions. So we're really impressed because you've nailed it 8 o'clock on the nose. So well done. One of the questions I thought was a really excellent one was about the small things that you can do in a quality improvement sense, particularly when you know, you yourself likes the idea of quality improvement, but the rest of your team might not be quite so on board. And what might be a small thing that could make a big difference, you know, to get people, because it's almost as if people need to also come on that journey with you to sort of believe that it's worth it. Annette, or anyone else? Katie?
Not me. Lou?
Sometimes it's not about the work things as well, it's about finding out what people really want to change. And often, you know, there are things like about having shared coffee resources that are paid for by, you know, the little things that actually can help people understand what the work is about before they feel you're going to cause trouble by going near the patients with some kind of dangerous change process. So I think sometimes it is about picking out something. Well, the most important thing is something that you can deliver on, so something you think you can fix, and finding out what those magic things might be that people really want to change and that have been driving them mad, and they often are small and they often are fixable.
I suppose it's a little bit like a bridges thing, where you need to actually get that feeling of success with something to then think actually going through another circle of change could then lead to further success. So it's actually getting the confidence in making those changes. And Lou, have you got any thoughts? You got anything you want to add?
You're muted. Oh, there you go.
Yeah, I know. Sorry.
We just sprung on you.
Sorry, what was the question again?
Okay.
I was looking on Twitter trying to follow all those new people.
I was just thinking about that sort of iterative cycle of just a small success and a small success. I think sometimes, I mean, I've been guilty of it, that when you see a model, it can be a bit of a turn off because it looks more complicated than it actually really is. But it nonetheless can give you that sort of structure. And I just thinking about somebody that just needs to be sold, you know, if you're trying to get the rest of your team on board with quality improvement, what might be some small things that you can do? I mean, open it up to everybody, but if you have a comment, Lou, it'd be nice to hear from you.
Yeah, no, I agree. I think you have to find the people who are willing to give it a go, and for them to go through the process and show everyone what the outcome is, and then I feel that people start to slowly come on board. And I think also the other thing that helps is having some help with structured problem solving. So I think sometimes the things you want to change feel very overwhelming, and that's what quality improvement, you know, your quality improvement team can help you with as well. Is it can be really powerful just to have a 1 hour session where you have help thinking through all the problems and all the things you want to try and change, and you know, seeing it on a page and then trying to prioritize, because I found that we're very good at talking about the problems and talking about what we think the solution should be, but not actually trying anything.
And it's that testing bit, isn't it, that's really important.
Yeah, I just noticed a comment from Debs Harding, who did one of our webinars, the one before last. Debs, you said about sometimes we're ahead of our colleagues with a solution and we haven't really brought them up to speed with all of our offline thinking. Could you just say a bit more about that, please?
I knew if I made a comment to do that. I think that sometimes, well, I think there's two things there. One is I think there are inevitably, and Annette sort of said this, there are a whole lot of things, if we stood by the coffee machine in the days when we were allowed to do that, we might all have things that we thought were a priority that needed to be fixed or we needed to address, but they might all be subtly different, or some of them might be, you know, quite different. So what Lou was saying about priorities, I think, is crucial, checking that we all have the same priority. And then I think, particularly if you're trying to lead quality improvement, I think you do a lot of, I think you can get into a mindset of thinking you have to deliver the solution. and having feeling the expectation or the weight of expectation upon your shoulders to come up with that solution. So when you then pitch up with your team and you say, well, this is what we're going to do and this is how we're going to do it, I think you forget you've done a lot of ruminating in the background and testing out possibilities and options, and everyone else is thinking, oh, why hasn't she thought about this, or why haven't they explored that? So I think there's something about, you know, making explicit where we are with the process and how we got there, and not assuming everyone else is on the same page.
Yeah, which often people aren't, are they? Any other comments about that? Any sort of examples or small changes that have been successful? Evie, I can see you got your hand up. I'm just going to go on to page 2 because I don't want to avoid page 2.
Can I just quickly say, listening to you guys makes a lot of sense, but for me it's just purely from my point of view, humbly, it reminds me a lot when you trying to work with us to teach us how to find our new normal, and you try to empower us, doing problem solving, going through options, making sure what worries us and working on those, and what the troubles we. Everything I'm listening here, it reminds me the way my therapist used to work with me to find the way forward, and working on our goals, we want to improve and get better. So I'm just thinking, for me, implying some of those skills you're already doing with your patients, and they all that actually Deb, Annette, Jen, everyone mentioned. I don't know.
Thank you. No, thank you, Evie. And I just actually, it's actually aligned really well with a comment that's just come in the chat box about and it's the thing is it's moving up, so I was reading it and then it's moved up a bit, so now the one I was looking at is now moving up. Okay, there's from Lindsay O'Connor said, any suggestions for positive ways to free up frontline staff to come up with ideas to be involved, as opposed to managers that aren't working clinically? So I've just that makes me sort of think about how, you know, people do need that time to sort of do that free thinking to come up with the ideas. And I don't know, Annette, Katie, anybody.
In Jenny's case, they got family members with COVID and had to self-isolate.
Yeah, it's a bit of an extreme way of.
Yeah, let's not advocate that as a way forward. And I think one of the things we found with the work we've done is it's about getting this is where the senior level support for this kind of work comes in, to free up people's time to get involved. One of the things that particularly the Point of Care Foundation do, I definitely would recommend their website for resources, is to when people sign up to do a quality improvement program, they send people, and they have to send a team of people to come and do training. So the idea is that it's a development opportunity for people as a team, and one of the things the teams say is it's really useful to go and do the training, but they also never get that time out together, so there's a secondary benefit for them as a team to have an opportunity to learn together, to travel somewhere together, to get that kind of input. But all of that has to come from quite senior leadership feeling this is important to their organizations, to actually free up people to do the work. It's not very, very time consuming, this kind of idea gathering exercises, but it still needs, people have so little time, it still needs that kind of buy-in from the people who make decisions about people's time.
And Annette, that's similar really to using something like experience-based co-design, where you actually get a group of people together to really, and I like the sort of, you know, what you said about the fact that it was often an emotive thing. It was a really, you know, coming back to sort of Maslow's hierarchy, and something around a basic human need that really stuck out for people, that then helped initiate that change as well, and getting people to stop and look in the way that you described, I thought was really, really powerful.
But it is also kind of emotional work for staff, and one of the, it needs that senior support for people to recognise that if you are opening them up to looking again at services and seeing very uncomfortable truths about how services are being delivered, they need the support to not only to be able to deal with that, but also that people are recognising the other factors that make those things happen, and people with the power to do something about that are also kicking in. So it's why quality improvement does involve people at many levels, and it doesn't work if it's just a very small team. down at the front line with no kind of connection.
Thanks, Annette. Charlie, could I bring you in? Oh, it's awful when you do this. You just sort of flipped onto page 1, so I can now see you. But Charlie, you've been involved with a lot of quality improvement work in your trust, haven't you? I noticed about this issue about people having that time and space to be creative, and be interested in some of your experiences, how you've managed it.
I mean, I think it's absolutely key. It was absolutely embedded in what we were doing pre-COVID. And as we've already talked about, you know, when command and control came in, I work in a community service in Cambridgeshire, and we have a stroke and neuro integrated team, but we still had to make massive changes in a really short space of time, as everyone did, you know, for very good reasons. But as we've begun to try and look at resetting and opening up the service into phase 2, what we started doing in groups is just looking at how we redesign the pathways now, because before we had very long pathways, you know, we could see people for a long time. It's very goal focused, you know, lots of kind of co-production, and that luxury has gone now for the moment. So what the teams have done is they've worked in groups to design shorter pathways, very much focusing on self-management and how we really support people to do that. Now, it's not perfect, but it's given them headspace. It's given them a space to get something down on paper, and their live documents. So we keep them in a Teams folder, and once a week at the moment, they're having some time where they talk about, for example, what return to work might look like working alongside somebody under COVID conditions. So they have a pathway return to work, and then they're thinking about how they've had to change that now from what they would do before because of all the constraints we're working with. And it's not a protocol, it's not prescriptive, it's the staff working through and then feeding in the patient's experiences, because their experiences, you know, people who access our services, the patients have changed as well. So it's really giving them a kind of lots of small PDSAs and giving them some control back in terms of what they're now being asked to deliver on, especially when we know that might all change again if there's a second wave. But it's a way of focusing that energy and giving them some real control and identity back. And I think that's true for the staff, the patients, the carers. I think that's been our way of approaching it.
Yeah, just quickly, Charlie, because I thought, you know, we've heard about services being decimated and being sort of completely pulled apart, and actually coming back together can be positive because you can stop doing the things that you didn't that weren't working. But in your case, there was actually a very good, fully functional, well-performing pathway, which can't be as it was before either. So it's interesting how, you know, from your perspective, you've actually got to just make that a shorter intervention pathway now.
Yeah. And the other thing I would just add, I mean, we spend our whole time on Zoom, and some people are quite comfortable with that and some people aren't. But by getting people to work into smaller working groups, it gives everyone a voice. And that was really important as well, actually. Yeah,
totally. Sophie, there's a question from you here. Do you want to say it rather than read it out, or sort of just summarize what your question is?
Hi, sorry. I was just thinking about the patients that perhaps aren't engaging through things like telemedicine and video calling and things like that. How are we going to ensure that we're making a service that represents them as well? Because the people that we might be speaking to about how our service runs are the people who are potentially more likely to engage, more likely to self-manage. They may be a different kind of group of people, and we don't want to make a service that just works really well for those people.
Yeah, great question. Has anybody got anything they would anyone like to respond to that? If you can just, Bridges team, or just...
Can I chip in on this one?
Yeah, well, go for it.
Yeah, so I think what's really key is that you don't just focus on one method of interaction, and I suspect this is probably something that we'll talk about in the next co-production webinar as well, but not just focusing on, say, video, like video conferencing, for example, not just having one method, so making sure that you're engaging with people, say, over the phone, over video, you know, old-fashioned letters and things like that as well. So you're really trying to meet people in the medium that they are more comfortable with, and to really try and make sure that you're kind of reaching all of those kind of demographics is a really useful way. But also in you know, as is kind of key in those, like the language, you know, the things are in the language that they are used to as well, so not using like quality improvement jargon and stuff like that, but actually, you know, kind of fairly plain language and easy to understand that language.
Thanks, Scott.
Is really key as well.
Jen, you had something that you wanted to say?
Jen, yeah, you're on.
I was just going to add that we're kind of really recognizing that obviously the patients that we're currently interacting with are those that are comfortable with telephone or video consultation, and that we're sort of recognizing that there are groups of patients that we're really struggling to support in a remote way, and I think part of this process has to be trying to make sure that we are talking to everybody, but it's also trying to work under such time pressures as well that sometimes it's doing our best in the short space of time to talk to as many patients as we can to start with something, and then try and keep evolving things as we go along. One patient that I spoke to made quite a pertinent point about how things are at the moment not being normal yet, and his view was kind of in relation to his fatigue and the demands of not actually having to go into work at the moment, and things were different. So when I was asking him kind of how he was finding things and how he felt the support we were giving him at the moment, just in view of sort of evaluating our service, he was like, you know, it's great, but this isn't what it's going to be like forever, because I'm going to have to go back into work and I'm going to have to be doing this. And I thought that was a really interesting point that you made. I was like, oh yeah, of course this isn't what it's always going to be like. So I think it's yeah, kind of doing what we can now, engaging with as many people as we can, and then continuing to use all of those different ideas like Scott was saying going forward.
I think it's also, I mean, I think asking any patient is better than asking nobody, because it'll still give you a different perspective beyond a professional perspective, and you're aware that they may be a narrow kind of subgroup of person, but if they're good at advocating, then they're still going to give you potentially a useful view. But I think what's really important is to focus on how you access that knowledge. So like Jen saying, I was speaking to a friend who was quite annoyed because she'd been told to do a patient satisfaction questionnaire with all of the people that she's talking to. She's doing remote musculoskeletal consultations. All the patients thought it was great because they're getting something, and they wouldn't normally get anything during what's going on. So they all rated it as like 10 out of 10. And then they were using that to put something in place longer term. And actually longer term, it kind of mirrors a bit what you're saying, Jen, like the current situation isn't necessarily going to give you information for what's going to go on in the future. And I think that's why the co-production and the methods that you use in co-production are really important, because you're not just consulting a patient, you're actually using a process to access that design so that they can be involved in the whole thing, if you see what I mean, rather than just asking them about a kind of the end result. But you get them, you enable them to be taking part so that they have a whole view of how all those different things fit together, the view that you might have as a clinician over the whole thing. Evie.
Yes, hi. I really agree with Katie with this, and there's just a tiny little example. When I was lying in hospital in Holdsworth Ward, St. George's, Paul came to me, my OT, and they were designing, it's just a tiny snippet of, they were designing brochures for pelvis injuries, for broken bones, to inform us pelvis injured patients, what is it actually about? And it had if I remember, about 8 pages, about this big. And he said, we want to redesign it, and do you mind have a look? This is just a draft, and this is what we're thinking might be useful to you. And I was really glad, because I had nothing better to do. B, I actually felt useful, and something bad is going to be used for something good. And C, quite a few things I crossed out that I thought, A, I don't understand it. This is too clinical, doesn't make sense, too long, too wordy. But there were also a lot of things that I actually found really helpful. Pictures, oh, this is really, oh, that's why I'm hurting. This is what I need to be aware of, and this is what to look out for, and this is who I can contact. And it was really helpful. And then Paul actually gave me feedback, saying back to me, saying that that was really helpful. But he went to another 80-year-old lady, and then another who was 50-year-old, and he was very good getting information out of us. I have to give him that. But it was really fun, and actually, apparently, they ended up with something that I definitely would read it as a patient. I wouldn't have read the first one, that would end up on my bedside table. But the other one, I was like, yeah, this is actually cool, makes sense. I really like it. But not only me, different ages, and I'm a foreigner, you know, what do I know? English is not my first language, but other ladies who were English, they did understand it, and we had a lot of fun. And actually, by the way, it got us talking between us as well, so it was actually quite great communication tool for peer support. So yeah,
thank you.
Thanks, Abby. So Nick put in the chat about actually during lockdown you can potentially reach a wider group of people. And certainly when we asked people to fill in that the quality improvement tool, the 2x2 square, one of the things that people wanted to continue amplifying was skill sharing. And we've got the sense that people are really willing to collaborate at the moment, which is really cool. And I think if you kind of stop seeing patients as them and us as clinicians, then patients are interacting with people in very similar ways than all of us are at the moment. So in terms of accessing a range of people to collaborate with, you just think about who you're in contact with each day, and also using patients to contact other patients can be really, really useful.
I wonder if there's also something, because Deb's put in the chat about having somewhere where you can actually sort of keep those QI ideas, hunches, thoughts, a little bit like Charlie was explaining, and also where patients can also post ideas, whether by text or something, you know. So there's a way of, remember this definition of experiences of everybody, and by harnessing that, you drive change on a lot more rapidly, because exactly as Annette described, you know, people then emotionally connect to the reason for making the change. So I wonder if there's something to take away from this about how we capture the ideas so that they're not lost. How do you do that then, Fiona? I like the idea of I'm really into the mural. I think the mural is a great idea, because I don't know how other people are feeling when you're just stuck at home. You lose that thing of just scribbling on flip chart or just writing or exchanging ideas with people. I know a lot of you are in clinical practice, but I think that's just a really important, so people can really, you know, maybe anonymously or maybe just as a thought comes to them, there's somewhere to post these ideas. I don't know, Debs, if there's anything you want to add to that. Anything else?
Not really. I just think having somewhere, you know, that people know they could, I think people are having hunches all the time about things that could be better.
Yeah.
And, you know, it's just having somewhere that you can capture those as you go along, because otherwise they're lost and people don't feel they've been heard. The crucial thing is to respond to them.
Yes.
Sometimes it's somewhere and sometimes it's someone, you know, to you know, put your hand up as the person, you know, if you got an idea, let me know, or, you know, so there's some repository for things, because sometimes it's a person.
I think that's a good point. Someone taking responsibility for it, not assuming that someone else has noticed it or that someone else is going to step up.
Yeah, and Nick says we've got a quality wall in Angola. There we go. That's a phrase I didn't think I'd be reading out tonight. I must admit, equality wall in Angola. But I'm liking the idea of having somewhere where it can be put, so it's not lost.
And there's lots of really cool tools out there that are just being made either freely available, or you just kind of become aware of them because people are tweeting about them or advertising them online. What Annette was saying, actually, Jenny, made me think of, it's kind of the opposite of what you were talking about, where you're like trying to stick your hand up going, okay, well, like who's actually doing the COVID pages? And like people are like going past and it's just no idea. So it's really, so actually those ideas are not particularly being captured necessarily.
Okay.
We've got 4 minutes.
Yeah, I'm aware of the time. We've actually had a fuller discussion this time, which not managed to do before. That was really great.
What I might do is just share the screen. So there are a couple of interesting points which started to creep onto talking about health inequalities, which is very topical because our next webinar will be on co-production, but the one after that we're going to have a slightly longer break, and we're going to do one in the beginning of August looking at health inequalities. Like many of you at Bridges, we've been thinking quite a lot about race and white privilege and healthcare, and so we're going to do a slightly different webinar. We're putting together a panel discussion which will be very MDT. If you know any people that would like to be involved, any good speakers, then do get in touch with us via admin@bridgesselfmanagement.org.uk. But then I think some of the things that you started to touch on here about who we're involving in shaping and designing healthcare services is actually very poignant for thinking about health inequalities and how those are continuing as we go along. So let me just share the screen. As always, what we would love to do is to get from you again, what's one word for how you're feeling now? And whilst you're doing that, I'll let Fiona read some of those out, but do email us or get in touch if there's any other webinars that you think would be useful. What was making you laugh?
I'd just seen Evie's message saying, "Oh, it's Jeffrey." It's
That's the dog for anyone that doesn't know.
Braver.
So we've been doing the webinars every 2 weeks. We're going to slow down slightly. So we've got 3 weeks now until the next one, which is on the 8th of July on co-production. And it'll be monthly, but so long as these are useful for you, we will continue doing them. But it's really important that they emerge out of what's going on at the moment for all of you and what you feel be an important thing to focus on or to discuss or to share your expertise on. So do get in touch with us.
Thoughts? We haven't had that many, so just anything, just one word. Be nice to just see
for how you're feeling right now in the chat window. Otherwise, you
really appreciate it.
So stimulated, contemplating, motivated, encouraged, inspired. I know that you're all using your free time this evening, and we really appreciate you joining us, and we hope it's been useful. So thank you very much.
Yes.
And goodbye.
And well done, everyone.
Thank you, Katie. Thanks.
You're not going to watch the football now.
Thank you.
Well done, everyone. Thank you. Well done, Jen, Annette.